Now the management, mild attack, what is mentioned there, we will come to this, the investigations, we will come. Okay, now the mild attack, you have to start with a fluid resuscitation and analgesia, no dietary restriction. No dietary restriction, that means what? Previously, they were trying to keep the patient MPO, and even they keep him on TPN without feeding. But nowadays they found that keeping the patient MPO, so we have a stasis of the bowel, and that will lead to bacteria translocation, and we will have infection. So they don't recommend to keep the patient MPO, and that's why it's clearly mentioned here, no dietary restriction. So we start the patient on fluid resuscitation and analgesia, and we can feed him if he's tolerating. And finally, the cholecystectomy is the definitive treatment and is ideally performed in the same admission. This is a very common question, that when you should do the cholecystectomy in a patient with acute biliary pancreatitis, you should do it within the same admission. After the patient improved, do not discharge him home. You have to do it within the same admission, the cholecystectomy, because around, I think, 50% they would come with pancreatitis if you do not remove the gallbladder. Severe attack, remember always ICU, then do whatever you would like to do. So first step is considering ICU, then whatever, depend on the condition, that oxygen supplementation, and again fluid resuscitation, and enteral nasogastric or nasojejunal feeding. You can see here, even in severe attack, there is no dietary restriction. You can feed him with nasogastric or nasojejunal. If will not give him PO, so we can give him through the nasogastric or nasojejunal. Then if he is not tolerating, you can shift to the total parenteral nutrition. And remember that there is a loss, which is third space loss of protein-rich fluid into the peritoneal cavity and interstitially, which is the third space loss. So the patient will develop really dehydration because of this third space loss. So again, mentioned intensive care unit, but put it at the beginning of your management in a severe attack. ICU, then do whatever you would like. Okay, C-reactive protein is a very important lab to be considered for the follow-up of the patient. And instead of ordering amylase from day to day, actually you need to order the C-reactive protein. This is the one telling you about the prognosis of the patient. So if the C-reactive protein is elevated more than 150, after 48 hours, complications are more likely. So this is telling you that the patient developing complication because the CRP is elevating. Prophylactic parenteral antibiotics are no longer recommended. Yes, this is another very important, because before they were giving the antibiotic, or considering giving the antibiotic as a prophylactic. If the patient developed pancreatitis, they don't want him to develop infected pancreatic necrosis. But nowadays, clearly mentioned that don't give a prophylactic antibiotic. You give it only in two conditions. Either you are confirmed with the patient that he has infected pancreatic necrosis, or you are suspecting the infected pancreatic necrosis. Suspecting, I mean by the finding in the CT. Finding in the CT that signs of necrosis in addition to the gas bubbles. So you are suspecting infected. And the confirmation actually for the diagnosis of infected pancreatic necrosis is done by the FNA. You take from that FNA and you send it to gram stain and culture to confirm it. Now, endoscopy and surgery in severe acute pancreatitis. Here I put query because it's mentioned within 72 hours you should do the endoscopy in severe acute pancreatitis. It's mentioned here, but actually if you read more advanced textbooks like in Cameroon, you don't do it as a routine for every patient, the endoscopy in severe acute pancreatitis. You do it in the two indications that I mentioned to you, in pancreatitis with a cholangitis or pancreatitis with CBD obstruction, and the duration of doing is different. Within 24 hours if he had cholangitis, or within 48 hours if he has CBD obstruction without cholangitis. And also one third indication, I really don't want to mention to you, that if the patient develop comorbidities and you do not expect that you could do for him the cholecystectomy, so you can do the ERCP and sphincterotomy. Forget it. Okay, now the timing for cholecystectomy for mild attack is different than for severe attack. For mild attack, you do it within the same admission, as we mentioned. But for severe attack, I'm against this point because he mentioned here before discharge, no. In severe attack, you do it later on. You delay it later. So you don't do the cholecystectomy if severe attack. If mild attack, yes, you do it within the same admission. If severe attack, you delay it later on, let's say after 6 weeks. Now, the surgical debridement, please don't mention the surgical debridement anymore in acute pancreatitis. You have to go step by step. You have to go with a conservative management. If that failed, you go with the drainage, CT-guided drainage. Then you have the endoscopic necrosectomy, laparoscopic, like the also retroperitoneal. Then you go for the operative. But all of these steps are so many steps we have before mentioning the surgical debridement. So don't mention surgical debridement for severe acute pancreatitis until you go with the steps, so many steps before that, including the, as I mentioned, the CT-guided drainage, endoscopic, then laparoscopic. Complication of acute pancreatitis. In severe pancreatitis, mortality reaching from 10 to 30%. I put it only because I want you to consider how much that is affecting the patient, the severe pancreatitis. It's really high number of mortality, 10 to 30%. Now, pancreatic necrosis as a complication. Pancreatic necrosis is an infection. Necrosis is identified using the IV contrast enhanced CT scan in which necrotic pancreas does not opassify, having lost its blood supply. What does that mean? That means when we have a necrosis, that means there is no blood supply reaching to that area. So what do we need to investigate? How can we investigate? We do CT scan for the pancreas with, it should include IV contrast. Because the IV contrast, I will see whether it's reaching to that area, to the whole of the pancreas or not. If it is not reaching, the area is not opassifying, so that is a necrosis. Okay, so we need a CT with IV contrast. Now, the infection is suspected by the CT, as we mentioned, by gas bubbles. And how is that confirmed? By percutaneous aspiration. So we take aspirate from that one, we send it to the gram stain and culture. Now, what else? Fluid collection around the pancreas, which is called acute peripancreatic fluid collection. There is actually a classification, which is Atlanta classification. I will not go for detail of that one. Atlanta classification telling you that the classification of the what are the complications. You may have acute peripancreatic fluid collection, pseudocyst, or the pancreatic infected the necrotic infected necrotic pancreatitis. So that is different classification, and it's not mentioned here, whether less than 4 weeks or more than 4 weeks, or whether wall is there or not. Pancreatic pseudocyst. Pseudocyst is not a true cyst. There is no epithelial lining. This is a very common question. That the pseudocyst, usually the cyst, it's formed from the true cyst. It's formed from the epithelium, but here we don't have epithelium. Yes, there is a wall, but there is no epithelium. So there is a wall, but there is no epithelium. This is in the pseudocyst. CT scan is the investigation of choice. What's regarding the management? The management, those around 6 centimeters can be safely observed for up to 6 months, provided they have typical appearance on the CT scan and are asymptomatic. This is really, it's changing. It's changing because previously they mentioned the size and the symptoms. Nowadays they mention only the symptoms. If the patient is symptomatic, you have to treat him. If the patient is asymptomatic, you can observe him. So whether this is less than 6 centimeters or more than 6 centimeters, this is not an indication anymore. Only the symptoms, these are the indication. But if the size is more than 6 centimeters, you expect that the patient may not improve, and he will need at some time the intervention. Now, the intervention is operation either by laparoscopy or open. Yes, it's correct, but you have to remember also there is an endoscopic cystogastrostomy. And this can be performed after 6 weeks. You need it to be mature. The wall needed to be matured before you intervene and do your intervention. Pancreatic abscess. nothing mentioned here. Now, what else here? Complication of severe acute pancreatitis. One of the complications is multi-organ failure, including renal failure, respiratory failure, and cardiac failure, and portal vein thrombosis, bowel ischemia, fistula, and late complications like the diabetes mellitus and intestinal malabsorption. Usually, or most commonly, the diabetes and intestinal malabsorption with recurrent attacks and with the chronic pancreatitis, honestly, more than the acute pancreatitis. Now, recurrent and chronic pancreatitis. Recurrent, that means multiple attacks and recurrent attacks. Chronic pancreatitis, important points regarding that you may not have elevated amylase level because the pancreas is starting to be affected, so it will not secrete that amylase, so we may not have the elevated amylase level. And in ultrasound and CT, you may have glandular swelling and dilated pancreatic duct. Sometimes, not always, you can find it in the ultrasound, on the CT. And ERCP could help you for the diagnosis of chronic pancreatitis. It's mentioned in other textbooks that this is the best to diagnose a chronic pancreatitis. It's the ERCP. So if for the chronic pancreatitis, it's the ERCP. This is the investigation of management, investigation of choice for chronic pancreatitis. Malabsorption or diabetes is more likely to develop than after the acute pancreatitis. Yes, as I mentioned, it's more with the chronic. Pancreatic calcification seen on abdominal X-ray is diagnostic of chronic pancreatitis. So when we do an X-ray, we may find the calcifications along the pancreas, and we will show it in the figure, and that is a diagnostic for the chronic pancreatitis. Unfortunately, you don't see it unless rarely. In the management of chronic pancreatitis, first you treat. Usually they present with the pain, so you treat the pain. You give them analgesic. If they are not improving, you try the celiac ganglion block. And later on, they may need to really in the intervention, the surgery, and the surgery depends on the duct. It's I think you're not supposed to know the details of that one, as it's not mentioned, whether this is dilated duct or small duct. And one of the operations is Besto operation, which is a lateral pancreatic jejunostomy. Now let's see this this figure. This is a normal one showing you the pancreatic duct, main pancreatic duct, and also the accessory duct. And here, there is a structure. There is a structure in between the two arrows shown to you here, the red arrows. There is a structure, and if you see the distally, it's really dilated. I mean normal in size, but in the beginning of the proximal is structured. Here, this picture showing you the calcification of the calcification in the chronic pancreatitis. This is actually CT. This is not an X-ray. As I mentioned, rarely you can see it in the to be shown in the X-ray. And here in this patient was not shown in the X-ray. It was shown only in the CT, and you can see clearly the calcification in the pancreas. And this is a diagnostic for a chronic pancreatitis. I think this is the last one. So this is only a summary for you for the acute pancreatitis. And as I mentioned, this does not substitute reading the textbook by yourself. This only to make it easier for you to read it from the textbook. Thank you.